distinguished speaker, Dr. Islam Anan from Egypt. Now, Dr. Islam Anan is also a lecturer of healthcare policy at Ashford University in California. He's a lecturer of pharmacoeconomics at Faculty of Pharmacy in Ain Shams University, that's in Egypt, lecturer of pharmacoeconomics and pharmaceutical marketing at the Faculty of Pharmacy in Future University. He's also the instructor of economic evaluation for the postgraduate faculty in Arab Academy for Science, Technology, and Maritime Transport. Almost 18 years in healthcare industry with academic and professional experience in healthcare and research consultancy. He's involved in around 500 research projects involving around 20 pharma companies. He has got 3,000 instructing hours to different entities and mainly based on applied pharmaceuticals and skills. He has been involved in the certification of 3,000 pharmacists in Egypt in the field of pharmacoeconomics. He's also worked for various bodies, including governmental bodies at the new HIO pricing committee for the Ministry of Health in Egypt, Lebanon, and Saudi Arabia. Dr. Islam Anan is a reviewer to many medical journals, including ISPOR Europe, International Society for Pharmacoeconomics and Outcomes Research. He is also an auditor, the ISO 20252 auditor for healthcare market research, and holds a diploma in pharmaceutical market research from the University of Georgia. Without further delay, over to you, Dr. Anan.
Thank you, Dr. Muhammad Arfan, for this marvelous introduction. Thank you all for joining me, and thanks for DUPHAT for the opportunity and the time to present you the basic epidemiological models and how we can actually interpret figures and numbers for COVID-19 pandemic. So I will be sharing my screen. So today's session, as I was just saying, we'll be talking about pharmacoepidemiology. And pharmacoepidemiology, it's a mix between the epidemiological models and epidemiology, which is the science of understanding the diseases spreading and pandemics, and the pharmaceutical medications involved in it and the utilization of medications. So that's my disclaimer on conflict of interest. So we'll begin with a very fast introduction for viruses in history. So whether this COVID-19 and the SARS-CoV-2 virus was the first one in the recent history or not, but actually, if we look back even before Christ, you will find that dissecting Egyptian mummies, they found that pandemics and viruses were actually spreading even through the pharaonic period. And they found that 1500 BC, a pandemic was actually present between Palestine and Egypt. They found as well that even after Christ was like 150 years only, there was another pandemic in Asia. Of course, the most famous one is the Black Death, which was in the 14th century in Europe. And the irony with that, Black Death was actually initiated from China, and because of rats and fleas, and the first country affected in Europe was actually Italy. So you can look back in history and you find that history repeats itself. Most of the viruses here you'll find initiated from places where there's a high interaction between human and animals. So that was the highest death toll. But if you look at the present and what we actually acquainted with, the pandemics of the recent history, the most lethal one was HIV. It took from 25 to 35 million lives from the 1981 till present. It's #1 in the current pandemics. And if you look at COVID-19, it stands on the 17th place. And it's actually progressing, and it will end, as most of the forecasted models, to be number 10 or number 11 in the death toll of pandemics. So we as pharmacoepidemiologists, before we were mainly focusing on infectious diseases epidemiology, because the death toll of infectious diseases in 1900, for example, was actually due to communicable diseases, pneumonia, TB, gastrointestinal infections, and so on. However, if you look at 2010, you will find that the main cause of death is actually heart diseases and cancer. So there was a major shift and swift in the causes of death through time. And now, because of the current pandemic, most of us as pharmacoepidemiologists and epidemiologists and health economists are returning back to our old books. We're returning back to studying again the small chapter was found in the universities about infectious diseases, and to see that it's very important to focus, not only now, or even in the future, to make us young and fresh grad pharmacoepidemiologists to focus on also infectious diseases. So where do new viruses come from? So if we have a normal virus, it should be within the same species. So viruses of humane are actually existing in humane and between human beings and human beings. Viruses of monkeys are only found in monkeys and so on. But what if a highly pathogenic strain from different species combined with a humane strain? This will make a new highly pathogenic human strain through a jump. And that's what's lethal and what's new to our human body. And because it is new, our immune system is not prepared. There is no antigen inside our immune system to defend it. So for the current coronavirus, SARS-CoV-2, causing the COVID-19 disease, the jump between different hosts was till now believed to be from anteater bats combined with influenza virus from human being. And that makes the reservoir hosts to make the index case. So the combination of three viruses and the mutation of them make it very new pathogenic to human being. That's why we're not being able to resist it. And then a human to human transmission happened, which is again a rare one. Most viruses and even most mixed pathogens only be transmitted from the host, animal host, to human. And we have a lot of examples for that. But when it's from human to human, this is the most dangerous one because it will be the beginning of spread, you cannot control it, and then it will end up with a global pandemic, which is in a very short definition, when there is no borders for transmission. You cannot control or seize the borders of the transmission. So if we look at the science of epidemiology, and the science of epidemiology, of course, it's very difficult to be shortened and just discussed in 1 minute. So I will just try to make it as fast as simple in one slide. So we spend most of our teaching time to teach our students this slide. You got a bathtub. This bathtub is half filled with water. Each droplet in this bathtub is actually a living patient with a certain disease. So this is what we call prevalence. So any living person with a disease is actually the prevalence, and beneath prevalence we have a lot of chapters, equations, and so on. And the bathtub and the tap still dropping water. The new droplets are actually new patients entering the patient pool, and that's what we call incidence. Some water actually made it and escaped from the pool and got their remission. Unfortunately, some droplets go with a drainage, and that's what we call mortality. So we spent like 1 or 2 years studying these 4 parameters, and this is the basics of epidemiology. Of course, there's a lot of advanced epidemiology, but if you grasp these 4 parameters, you'll be able to read the models coming from incidence-based models, so it's new cases only, or prevalence-based models, or mortality models, or remission models. And these are the 4 main pillars you read every day for coronavirus. So if the disease is only sporadic, which is occasional cases occurring at irregular intervals, we don't focus much on it. But if it's endemic and its persistent occurrence was low to moderate level, like Ebola first emerging was like an endemic, then it became in Africa hyper-endemic with persistent high level of occurrence, and like MERS, for example, the Middle East one. And finally, when it's an epidemic, it means its occurrence in excess of the expected level at the given time period and the beginning of exponential growth. And then it goes global, and it's a global pandemic. So what we are trying to do with epidemiology, and this slide, it's the core slide of our presentation today, and it will continue till the end of the session. We're trying to look at data in the epidemiology and find signals. And data is actually raw figures and meaningless, and we try to make it useful by adding meaning to it. And this is when we call it information. And if we have the current and efficient knowledge to interpret the information, this is the third pillar in the DKW pyramid, the knowledge pyramid. And if we know what to do, it means in healthcare, we have a healthcare policy. That's the top of the pyramid. We have the wisdom to apply our knowledge to interpret information to get way forward. So to give you a very simple example of that, even outside the pandemic, if I said 190, it's just a raw figure, it's just data, and it's meaningless. But what if I told you that 190 is a systolic blood pressure, and now I got an information? So the knowledge is it high? Yes, it's high. So I have the knowledge because of my studies, because of my experience. So should I really manage this patient and try to control the systolic blood pressure? If I know the answer and I try to do it, this is wisdom. So what we are trying to do with the pandemic is to read the data coming from the WHO and all the Ministry of Health every day, interpret the data to form information, make some models, pharmacoeconomics model, pharmacoepidemiology models, and then try to apply health policy. So we'll be talking very quickly about the fourth. So let's look at the data. And we're not going to spend a lot of time here because I know you see this chart from WorldMeter every day. And we've reached like 8 million so far, with the new cases of 88,000 today, as of yesterday, with a total deaths of 434, total recovery of 4 million. And we have something here, which is total test, for example. Because there's no total test for the global, that's the total test of Egypt, for example. So we have a lot of parameters. So if you look at this chart, and we've just mentioning prevalence, for example, which figure is the prevalence here? I will give you a second. Think about it. We need to find the prevalence. So it's not the total cases. The 8 millions are not prevalence, because the prevalence, we were just saying that the living cases. So we need to exclude deaths. We need to exclude total recovered. So it will be the active cases. So most of models are based on the active cases, which is very important. Of course, all the pillars will give different information, but just to give you that data sometimes might be misleading, as in, for example, coming for Egypt, and I will be talking about Egypt, UAE, KSA, and Jordan, these 4 countries. And Egypt is the most difficult country to predict or make any models because the high population, or more than 100 millions. And one other thing is we do have a low number of tests. We are working on a reactive testing, and we'll be discussing that. So this is will be the difficult model. The rest of countries will be easy. So if you look at data only, and you're gonna look at the deaths in Egypt, you will find 1,575 deaths. So how can I read it? This is only data. How can I make it information? So to read it, you can either relate it to total cases, and that's what we call a case fatality, and it will end up like 3.5, and you will begin to think whether 3.5 is high, 3.5 is low, but actually it's only depending on the total cases, and the total cases depends on the total test. So it's not that reliable, because if you do, and instead of Egypt is now like 200K tests, if you do like 400K tests tomorrow, the total cases will be like 100. So this will drop the case fatalities from 3.5 to be 1.5. So it's not that reliable. you can also relate it to the population or the population at risk. So if you consider that the total population is at risk, you can relate it to the 100 million. So we'll end up with 15 deaths for each 1 million individual living in the country here in Egypt. The global one is 56 for every 1 million. So you got different ways to look at numbers. And to understand even the relation between figures, you need to understand whether the country is going for reactive testing or a proactive testing. So reactive testing is like what we are doing in Egypt and Algeria, for example, in the Middle East, where the PCR tests are limited and it's not random. You wait for the patients to come at your premises, then you do the test and try to trace who actually contacted the case infected and try to make the test as well. So you will end up with the cases with diagnosed and clear and symptomatic and coming to you at the hospital. So if you are talking that 80% of the patients for COVID-19 are asymptomatic or with very mild symptoms, so it means you are missing huge number of cases not recorded on your system. However, if you are doing proactive testing, so it means that you are randomly screening subjects, even if they are symptomatic or not symptomatic, asymptomatic. It's a very expensive strategy. However, it will give you an excellent estimation of the cases. You can do statistics easily. You don't have a lot of prediction and assumptions. And even you can have a better health policy because you got good preparedness of the healthcare to get ready with ICU beds at time. If you know that you got a lot of pre-symptomatic cases that will need treatment, like in 2 days or 3 days, you will get ready to that. So this will be highly associated, the strategy, if you got high cases or low cases, and you can relate it to each other or not. So looking at who's doing a lot of tests in the region, and if you filter reward meter by the total tests for each 1 million population, you'll find that UAE is a top country in the Middle East and Africa doing tests. You will find in 17th place is Qatar, the 25th place is Kuwait, the 60th place is Saudi Arabia, then 65 Oman, 66 in Jordan. So you can actually look at numbers for the total tests, but it will be misleading because you will find, for example, the population of Qatar is like 2.8 millions versus around 10 millions in UAE versus 4 millions in Kuwait. And if you look at the total tests, it can be sometimes misleading. So it's better all the time to look at the total test per 1 million population and related to the new cases, whether there is a relation or not. And you will find it linear. You'll find whenever a country is doing more tests, they are discovering more cases. That's why we're all the time saying that the number of cases is not reliable if you are doing reactive testing strategy. It's more reliable if you are doing a proactive strategy. And even with a proactive strategy, the more tests you are doing, the more cases you will find. So 2 countries doing proactive testing in the region is UAE and Saudi Arabia. UAE is doing like 2.6 million, which is giving us a very good prediction about the curve itself, whether it's actually really declining or it's only because of the number of tests, and whether you can predict the end of wave 1 or not. And you will find that with 2.6 millions in the UAE, it's easy to look at the curve and say, yeah, it's self-explanatory. We don't have a lot of work to do here as epidemiologists. We need just to predict the previous forecast, and even a 5th grader can predict when the wave 1 will be finished. For Saudi Arabia, it's a bit more difficult because it is still a proactive testing, but with higher population. We're talking about 35 millions and only 1.1 million tests. So somehow you need to put a lot of assumptions for this figure, and you need to work with the mortality model, not only the case model, and you need to make an SIER model, which will be the next chapter. So how are we going to build the forecast model? So we've been talking about data and how we can actually make data into information. So now we'll be talking about knowledge. So the first model, which is most of countries are actually doing, is SIR model. Which is SIR model? They are talking like, if you have a situation of a disease, some individuals will be susceptible, which means they can get the infection. Some people will be infectious. They can actually infect other people, and some people will be recovered. This is the simplest model. However, if you can put figures for each country, so for example, I have 2 million susceptible, infectious, and recovered. You are missing one thing. You are missing the exposed for COVID. So that's why we are working as well with SEIR model. We are adding exposed, which is people who are got and carrier of the disease itself, but not yet infectious. So they will be infectious in a sigma time. And because of even in COVID, sometimes in rare cases, the recovered can go back and be susceptible again in the same season, but definitely they will be susceptible again in the next season. And we began to draw the curve with, for example, this is if we are talking about the R naught is 5, and we'll be talking about R naught in a minute, of a population only of 1 million, with incubation period of 5 days and recovery of 7 days, you will find that most curves of all diseases are the same. This is a very relieving curve, by the way, because looking at this curve, it means that you don't need all the population to be infected. You don't need all the susceptible to be infected in order to wave 1 to finish, which is an optimistic scenario, and that happened with all diseases and all pandemics in the history. Otherwise, there was no human being alive from the first pandemic. So you will find that at a 30% to 40%, the exposed begin to be somehow infected, recovered, and you will find that the recovery curve will be prolonged again. However, this model is actually missing the dead cases. And here's what we are actually working. So for Egypt, for example, we work with the most sophisticated model because we're not sure of the cases susceptible, we're not sure about the recovered, we're not sure about the dead. So we combine it all in SEIRD model. So we're adding the dead, and the curve will look like this. Of course, we're not going to go through the advanced epidemiology, it's just only from the surface. So we added 5% case fatality. And again, this is the worst case scenario, and still we don't see that the whole population is getting infected. So what's R naught that we keep saying? R naught is the average number of people that one person with a virus infects other healthy individuals. So for example, one person with H1N1 will infect 1.2 to 1.6 healthy individuals. Ebola is from 1.6 to 2, SARS 2 to 4, and MERS it will from 2 to 0.5 to 7. It was very lethal. So for COVID-19, it's from 2 to 2.5. It means one infected individual can infect 2 to 2.5 healthy individuals. So if we look at Egypt, and as I told you that the Egypt model is the most sophisticated one, and this slide is from the Ministry of Higher Education. They tried to see whether one person will be infected, how many healthy individuals, and they took it from the basic thing, which is week after week, what is the average gross? And even if there is an error, a high error in the recorded cases, and for each recorded cases, you will have a lot of unrecorded cases, but you can say that if it's constant, for example, if I'm only recording 20% of the figures, and after a week, it's 20% of the figures, I can somehow work with figures as if it's constant. And they said that it's average 1.4. And here's that they are calculated each week, not every day. So the gross was like 5% to 6.5%. And they ended up saying that the R naught of Egypt is 1.4. 1.4, it means that 10 subjects, infected subjects, will infect 14 healthy individuals to end up to be 24 infected individuals. And then this figure will multiply as per the new infections and the time. And the time here was for Egypt estimated to be 5 days. for the current infection times R naught. Of course, this equation is missing the acquired immunity, because after a time of infections, we have acquired immunity for the infection. And luckily, that happens with our immune system. Otherwise, the first pandemic would have eradicated human being from Earth. Another way to look at R naught, this is a very interesting slide. If you have a Google Maps on your mobile, Google Maps trace and track all the courses and all the movements that you are doing, and then accumulate and aggregate the data and sell it to people on reports. Of course, with confidentiality and everything, your data is without your names or pictures, but accumulated data, you will find that people in Egypt on the 12th of March, because there was actually a storm, they stayed home. So at Google Maps, no one moved. And Google Maps, they actually track your movement to where exactly. So, for example, they will say in the report, 30% of population moved to pharmacies, groceries, even moved to clubs, moved to supermarkets, to move to any places. You will find a very detailed report. And then they started to be outside their homes. Then there was a good fear from the pandemic. They stayed home. Till Sham al-Nasim holiday, they stayed home. And suddenly before Ramadan, most of Egyptians were actually in the streets. So what happened? The red one is the cases. You'll find a strong linear correlation with the daily cases with staying home. So you stay home, no new cases. You go out in the streets, there's a lot of new cases. So if you compare Egypt to Lebanon and Jordan, you'll find that Jordanians they actually stayed home. You know, you can see the curve. They're all at home. All Egyptians are in the streets, and Lebanese people are in between. They are going out, staying home. They got some march to do and return back. But the curve of Egypt was actually very funny. We cannot stay home, sorry, as people. That's in our blood, our culture. So it was reflected in a lot of cases. And you can see now that you got 44.5K diagnosed cases in Egypt. And as we are saying, for each diagnosed case, you will find 5 to 10 undiagnosed cases, which is normal, by the way, for any disease. It's not only for pandemics. So for diabetes, for example, for each diagnosed case in diabetes, you will find one undiagnosed case of diabetes. So in here, it's high because the asymptomatic figure is high as well. So we have different scenarios for it. That is the main curve. And once we had 10,000 cases and 500 deaths, it was the maximum healthcare capacity for Egypt. We had to extend the healthcare capacity. We had to work on the first optimistic scenario. That is the scenario of the Ministry of Higher Education and Scientific Research. They made a scenario that we're going to reach the peak on the 15th of June to hit the end of wave 1 by mid of July. But unfortunately, it seems that we are heading higher than this scenario with the second scenario. Still not the worst case or the pessimistic scenario, but the figures are still moving up. So we are expecting at the 1st of July that the SIERD model to reach a saturation within the susceptible people, and there is a acquired immunity will happen by time, maybe no large impact, a huge impact, but it will affect the curve to end by August with only 620,000 cases. And that's, of course, recorded cases and unrecorded cases. So, for example, it can end in the recorded cases on the system with like 70 or 80 K only cases recorded, but reflected. If you multiply by 5 to 10, it will be 620. So that's information, knowledge from the pandemic and what we are actually doing with the figures. Of course, these figures, and all models, they depend on the R. If the R is not 1.4, for example, it became 2.4, the model will change. It depends on the healthcare capacity. If you have a poor healthcare capacity, it will change. It depends on a lot of factors. On masks, for example, if you are not wearing mask on the street, the R will increase. So this will lead us to the last pillar in the pyramid, which is health policy, and the last part of my presentation. So how we can eliminate viruses. And this is the big question. And that's the wisdom part. So to eliminate novel viruses, it can be from natural phenomena. It can end on its own, for example, like SARS. So for SARS, the wave was like 8 months. And after 8 months, it disappeared. We wake up in the morning and we found no virus. So it can happen. And we wish it will happen with SARS-CoV-2. Or to have a vaccine, something like polio, for example. We do have a good vaccine for polio. Or we do have a good medication, whether the medication is repurposed or a new medication. Repurposed, it means that we do have a medication for another disease and we're going to repurpose that medication for COVID-19. And currently we don't have any novel innovative medication for COVID-19, so we have a repurposed ones like remdesivir, which was a repurposed from previous pandemics by Gilead, and and currently the Avigan from the Russian Ministry of Health, which is still with no published data so far, working on favipiravir for influenza, so repurposed to COVID-19. Or what we have in hand is social distancing. We do social distancing. We cut the chain between any infected case and a healthy individual. And we do have an R node less than 1. So 10 are infected 14. And instead, 10 will be infected 9 or 8. So the curve will be actually declining. And it got a very good impact. Look at these charts, for example. And don't panic with a lot of charts. Just look at the purple color. The purple color is social distancing. If you increase the social distancing, you'll find that the curve, the green one, is actually moving back. You'll find that the green one here is actually flattened. Increase social distancing and mask, it's better. Increase it more, it's better. See the green one? And then if you do a perfect social distancing and wearing mask in public, you'll find a very flat curve. So that's the effect of social distancing. And that's how most of the countries who ended wave 1 in the Middle East or worldwide have done. They have done and applied social distancing. So the health policy that any country would like to achieve in order to end the pandemic is what we call a VORGES, which is the German system, the 4 S's, which is space. We need to have a good space for patients, staff, supplies, and system. There are 4 S's. If you can actually work on them, you will go from the pandemic safe and with the least number of cases and deaths. For space, we're talking about to have a needed capacity for the surged number of cases going to your intensive care and hospital, criteria to designated hospitals that are going to receive the COVID-19 patient. You need to regulate patient flows inside the hospital. We need to postpone all elective surgeries. And of course, you need to accelerate discharge from the hospital so you have more space. You need to optimize current developments and develop alternative delivery platform. For example, you need to make virtual counseling so you can actually have more space inside the hospital. You need to repurpose and purchase capacity if you cannot have enough capacity. And that's done through a PPP, public-private partnership. You can rent and hire space in private places, hospital. For staff, we are talking about 2 things. Quantity, you need to increase quantity. And we have seen in US that they asked for many physicians from other countries to come. We also for quality, you need to upskill, make capacity building for the staff. You need to repurpose, for example, dermatologists to be able to treat COVID-19. So give them enough training. You need to get academic doctors from the medicine schools and train them how to diagnose and treat COVID. And that's what actually happened in all countries. Ensure safety and protection equipment for them and take care, and this is very important, and take care of their mental health. These are people working 24 hours, 48 hours, sometimes 72 hours as a shift. So you need to take care of their mental health. Supplies, and in supplies for COVID-19 and all pandemics, it's preferable to be having a centralized purchase mechanism, centralized one. You don't let it for the black market. You don't let the suppliers to be from retail places. So we can identify and resolve bottlenecks. You can actually get better prices when you actually import supplies, ensure that you got all the essential and emergency product and equipment list for procurement registration, and assure that their products are actually from QA perspective are technically fit, and define criteria for the usage. For the system, which is the fourth pillar and most important, you need to define the chain of command. That's very important. You need to have a task force of action. And if you see in February, who's actually responsible for the pandemic were the Ministry of Health all over the world. Then it became the prime ministers, and then it became presidents. So to define the chain of commands, it's very important, as huge as the pandemic, to be fast in declaring it. For example, most epidemiologists during mid-February said that we are heading towards a global pandemic. It's better not to declare it from the WHO, because each day delay in health policy, it will make huge impact on the cases. Some people said, no, we need to get ready before declaring global pandemic. These are the topics discussed based on data, information, knowledge, and wisdom. You need to define whether you're going to go for R&D or production, process of identification, case presentation, and reporting in your system, lockdown scenarios, whether you're going to go for total lockdown, not a total lockdown at all, like Sweden and UK in the start, and they regret what they have done and said that no lockdown was a bad system. A total lockdown like Jordan was very beneficial to Jordan and flattened the curve, or a halfway lockdown like Egypt is actually doing, which is a very difficult scenario where you need to reach equilibrium between managing the number of cases and in the same time trying to make the economy nourish and not to lose a lot of money from your gross domestic product. To have a hotline, a very important one, to have a good awareness campaign for the general public, and to establish a public-private partnership. So these are the 4S coming initially from the WHO, applied very good by Germany and a lot of other countries. And we can see that most Middle East countries are applying some countries are applying even more from the 4S system, which is a global system for health policy. And this will enable countries to end wave 1. And actually, I took the curve of Jordan, so that's Jordan now. If you can see, the reached the peak, very low cases. If you look at new cases, there is no bell-shaped curve. And that's a perfect thing to do. It's not to reach a bell-shaped curve like Germany, for example, to flatten from the start, make a total lockdown. So my way forward and conclusion for today's session, there's 13 steps to end wave 1 worldwide. So you need to increase number of tests. You need to go for the proactive phase of testing for countries doing reactive one. So we can have a high estimate of the spread, a right forecast for the future, and be able to draw the right policy on time. You need to adopt other techniques for recording COVID cases of the governmental system. If you do have a shortage in PCR, you can depend on other ways to diagnose it and record it on the system. You need to apply medical registries through medical application or mobiles for home quarantine patients, which is very important. You need to track home queue patients, whether their case is actually getting better or getting worse, so you can get ready, whether by ICU beds or even to make your data look better. If you put the recovered cases from home queue on the total recovery cases, you will have a good statistics, because in home queue, you got 95% recoveries, whether in hospital, you got like 80%. So if you put both, you will find better results in recovery. Of course, we need here to mention that in Morocco, they've reached 90% recovery rate. So we need to look how they can actually do it by diagnosing and treating and recovery, fast recovery and discharging of cases even in home queue. Open the economy on 3 phases, minimally 3 phases, not one time, because we've seen in China, we've seen currently in Europe, they opened the economy and they got a surge, a resurge in cases. You need to do quantitative assessment of each phase. Do not go to phase 2 in opening the economy for assessment of wave 1 or phase 1. And if phase 1 is not satisfactory, do not go to phase 2. You need to expand the healthcare capacity by ICU beds. You need to do a public-private partnership to include private hospitals to the system by subcontracting or any other mean of contracting. You need to incentivize healthcare workers, whether financially or non-financially, to motivate them during this crisis. You need to control provinces, cities, or governed rates. It means that for health policy to be efficient, don't look at the country as a one place. Look at the country as if it's bricks and cities, and make different health policies for different cities based on the figures and the curve. So one curve for the whole country will be misleading, because you're going to make a total lockdown for the country and you got a lot of cities and governorates with 0 cases. You can lock down the cities and the provinces and make the economy nourish in one city and close the economy in another, so you don't have a total loss for the whole country. You need to oblige large businesses and factories, if you are opening the economy, to have social responsibility and pay for their employees' safety, even pay for their masks and gloves and all their safety equipments. You need to increase the capacity of the public transportation if the country got public transportation, so you can have social distancing and no crowdness in public transportation. You need to enhance digital infrastructure, digitalization of government, encourage people to work from home, launch massive awareness campaigns, not only through social media and TV, but also face-to-face for people, for illiterate people who cannot read and write. And last point, and not least, is to have and ensure enough supplies of personal protective equipment, masks and other protective gear to all healthcare workers, citizens, with reasonable price, as well as to ensure its supply. That's it for the intro of epidemiology till we reach health policy, coming from data, knowledge, data, information, knowledge, and wisdom. Thank you, and I'm open for any question.
Thank you very much, Dr. Islam Anan. That was a beautiful introduction on epidemiology, and the way you structured it, explaining the knowledge pyramid from data, information, knowledge, and wisdom, and going into the details and guidelines. That was very, very informative. And I'm sure that all the delegates have enjoyed. I don't see many questions as such. So can I ask the first question itself? Now, in your epidemiology studies as such, what is the probability of having a study concerning avoidable mortality? Because this is one of the concerns many healthcare systems all over the world have been exposed to, the fragile healthcare systems they have. So probably this would be a very interesting point to see the avoidable mortality and morbidity. I'm referring to the potential to avoid death from a number of specified causes, considering the healthcare systems if action were taken.
Okay, so if I got it correctly, so we are talking about making a model for avoidable cases, deaths, and yes, and how to increase. Yes, this is a very good question. And actually, this will be part of the SERD model as well, because it's very important, and it's a beautiful question, to put the healthcare capacity and to segment between the highly susceptible people, healthcare workers, and the low susceptible people like children, for example. So doing that, you will have more specific health policy coming from it. You will have better understanding of the figures. Maybe you need to allocate different budgets for different segment of people for protection. And that's why, for example, led to a very good point in health policy, which is for vaccines. If a vaccine is present, we will not going to be giving vaccines to all people. We'll prioritize vaccines for healthcare workers at first. Then for people highly susceptible, it means with any comorbid condition, then healthy individuals. So yes, models contain actually capacity for healthcare system, contains segmentation between highly susceptible and low susceptible individuals and groups.
Thank you very much, Dr. Anan. I'll take some more questions here now from Noor El Shair. Her question is, we all know that Spanish influenza had a strong impact in the second wave. So where does that lead us for corona? Would history repeat itself? And what can we do as clinical pharmacists?
Yeah, that's two wonderful questions. So the first one is about wave 2, whether we are expecting a wave 2 like Spanish flu, which is more vicious and with higher surge in numbers, or a light wave 2. So in history, we have two things. If we are looking on corona family, so SARS and MERS, and we hope that SARS-CoV-2 is a good brother to his brothers and their family, we will have a good wave 2. Because SARS and MERS, we're still having waves of SARS and MERS, but it's very light one, no symptoms, no deaths, and that was immediately after wave 1. So it will gonna behave like SARS and MERS will be having a good wave 2. If not, it's like influenza, it will be the same wave, like the seasonal influenza. If it's gonna be like Spanish flu, it will be in fall or in winter, and it's gonna be worse. So what shall we do actually in pharmacoepidemiology and in health policy? It's better to expect the worst case scenario and get prepared to it. So it's better to think like it's gonna be like Spanish flu. I need to get ready with hospital equipment. I need to get ready with all the 13 points that we actually went through minutes ago and be ready. If it's gonna be like Spanish flu, I'm ready, it's good. If not, it's good as well. But what if I'm very optimistic and I'm thinking that it's gonna be a beautiful wave 2, it will be like other corona family, and I'm not prepared and I'm shocked with a bad wave 2. So in health policy, it's all the time better to get prepared with the worst case scenario. As a clinical pharmacist or a community pharmacist, we need to have the same precautions for wave 2 as you've done in wave 1. Do not expect it will be better, so we get prepared. However, put a smile on and keep optimistic because it's actually going to enhance your immunity. So
Thank you very much, Doctor. The next question is from Khalid Al-Matrafi. Now, this is a question where he talks about epidemiology and mortality rate. He asks, thank you, Dr. Islam. Why there are differences in the mortality rate from one country to another? So he takes an example. If we compare KSA, that is Saudi Arabia, with Canada, both are having almost the same number of population, but the mortality is so high compared to Saudi Arabia.
Yeah, it's a very good one. So there's a lot of things related to the mortality itself. If we are relating the mortality to the cases as a case fatality or to the population, and in your example, you've related to the population, which is a very good one, so thank you for this point. We do have some variables. We do have a range, of course. The range is we have mortality from 1% till it can reach up to 7%. So there's a range, but it depends on how young is the population. So for example, in Saudi, the average age is 29. So it is a young population compared to Canada. And we all know that most mortalities happen to people above 50 and 60, which is a higher segment in Canada than it is in Saudi. It's also related to number of travels for elder people. So in Canada, you will find that the travel between Canada and different countries and between American countries, it's big and high between elders. In Saudi, you're not going to be having traffic, a lot of air traffic for elder people. Another variable is how soon are you actually taking your health policy measures? Are you making the lockdown very quickly? The elders are actually staying at home or not? So Canada, for example, a lot of elder people are living alone. So they need to go out in the streets, for example. On the contrary, which is a good thing in the Middle East, for example, in Saudi, most elder people from the beginning of the pandemic were staying home and their families are taking care of the grocery and everything. There's a lot of variables. From the basic one, which is we do have a range, there's not a fixed range of mortality, till the extrinsic variables, which is related to the movement of the elder people in both countries. So thank you for the question, it's a very good one.
Thank you, Doctor. The next question is from Norhan Muhammad Abdul Hafiz. Hi, Dr. Islam. I want to ask two questions. The first one, by models, can we forecast the use of masks properly impact on number of cases and proper PPE use on number of healthcare professionals' deaths? The second question, with the different models and peaks for every country, will second wave timing be different and may happen or not in certain countries, or will it begin at specific time globally?
Okay, that's a beautiful two questions. So if I remember correctly, and thank you for giving me an opportunity to speak about the masks and the PPEs, because that's what we actually have in hand right now. And there is a lot of models talking about the impact of wearing masks to decreasing R naught, the R naught, which is the measure of infection spread. So if people are wearing masks, there is no transmission between infected individual to healthy individual. So the curve will decline very fast. So it got a huge impact on the curve. Even if it's just a cloth mask or a normal one, not even surgical, it will decrease or even prevent the droplets containing viruses from infected people to reach healthy individuals. So if you look at the countries applying obligatory masks in the streets, you will find that the R naught or the spreading of the virus is actually declining. Exactly the same for PPE for healthcare workers. So that was the first question. Can I remind you with the second one?
The second question is about the second wave. Will the timing be different, or it will happen or it will not happen in certain countries, or it will begin at a specific time globally?
Yeah. So for wave 2 timings and whether it's going to happen for all or not, it again depends, unless there is something related to immunity that we don't know. It will depend on will the country open the borders with other countries or not. That's the first variable. So for example, in the some Scandinavian countries made what we call a travel bubble. So travel bubble, it means that the two countries got 0 infections for more than 3 weeks. So they open airlines between the two countries only. And then when a third country is actually got 0 infections in 3 weeks, they will be added in the travel bubble and so on. So if you are going with this strategy, you may have no wave 2. However, for other countries opening the borders and so on, you can have a wave 2 in fall or in winter, and the number of cases might be different. For example, Italy can have a very light wave 2 versus Africa can have a very strong wave 2 compared to wave 1. It all depends on the acquired immunity for the individuals. It depends on the amount of travels, and it depends on one thing actually. We have 8 million cases right now, and it all began with 1 case. So wave 2 can also begin with 1 case in 1 country, and you have exactly the similar cases. So we are actually moving in the dark a bit for wave 2. So we're trying to, as I just mentioned, put a lot of scenarios, pick the worst case scenario, make health policy for the worst case scenario, and be optimistic it will never happen.
Yes. Thank you, Doctor. Now, the next question is from Amira Maharuz. Now, she is asking the same question what the earlier person had asked, and you had already answered, but there is a slight difference here. It's regarding the mortality rate between different countries, like the earlier example of Canada and Saudi Arabia. Now, her specific point is it linked to different viral strains or difference in just healthcare system?
Yeah, good point, Amir. So it is related to a lot of factors. as we mentioned, mortality can be related to the virus strain itself, but we don't have a confirmed study published in a high impact medical journal stating that there is a mutation in the virus that changes the structure and the impact of the disease on it. We do have a lot of assumptions on strains, and L strain, S strain, different things and so on, but not yet confirmed. So it can be the reason. Other reason is, as you mentioned, exactly. And third reason, it can be the mobility and average age of the population. So we do have a lot of variables for the different mortality rates. Immunity is a major factor that plays a huge role in that, but we don't have a lot of information about. But of course, mutation, for example, and if we talk about mutation in a minute, mutation sometimes happen by time without interfering from human or any intrinsic factors. So mutation can happen to be lighter or heavier or more vicious, or the mutation can happen when you try to resist it. It's like pests, when you try to eradicate pests in agriculture, and you got a new generation which is more resistant to pesticides. Viruses will do mutation when they find that you are trying a lot of vaccines, which is not that effective, and you are trying a lot of treatment, which is not that effective, and you are harming its existence. So they are trying to live better by mutation and try to exist better in our bodies by mutation. So far, there is no reason for SARS-CoV-2 to do mutation because it's existing just fine. There's no vaccine, there is no treatment. So that's why we are all the time talking that I better be waiting for a very good vaccine than trying a medium quality vaccine tomorrow.
Thank you, Dr. Anan. I think the next question is also related to some of the questions earlier, but I think the curiosity is on a very specific factor here. From Halima Khalil, why some countries like Norwegian have high number of treated cases while others are low?
Okay, so in recovery, right?
Yeah.
High number of recoveries. Yes. So some countries you will find that they treated all cases, even more than 90%. In the Middle East, you will find Morocco and some other countries, Jordan, for example, they treated all cases. So why you got higher recoveries in a certain country to another country? And even if we are not comparing Norway, if we're comparing Middle East countries with similar cases, you will find that some countries got better recovery than others. It depends on a lot of things. First is logistics. So when are you considered a case, a recovered case? So for example, we had some delays in the recovery records in UAE, for example. And that's not because people are not getting the recovery, it's because they are not discharging cases from hospital unless they are 100% sure they are totally recovered. So they discharge after 3 weeks. Other countries, they discharge and record on system after 1 week of recovery. So the first reason is logistics and administration paperwork. Second will be, are you early enough to treat the cases or not? So, it begins with upper respiratory symptoms and a lower respiratory system symptoms. So if you are treating from the early beginning, you will have a high recovery. And this is the main thing. If you don't have a good capacity, preparedness in your healthcare system to discover early cases, you treat them as early as possible. The antiviral will actually work. However, if it goes to the lower respiratory symptoms, and you need oxygen, you need ventilators, it's very difficult to treat. So it all begins by early detection and early treatment.
Thank you, Dr. Anan. The next question is from Hiba El-Tantawi. Now her question is regarding the RO. Now she asks, supposedly RO reflects the infection, then why MERS had RO of 7 and didn't cause a pandemic issue?
Yeah, that's a very good question. So even you will find other diseases with higher R, but it was not a pandemic. So every time you can be able to seize borders for any disease or pandemic, it's easy to eradicate it. So for Ebola, for example, for SARS, for example, it was very easy to close borders detect cases and put them aside and treat. So that's the first one. There is no open borders for it. Second, which is the main cause, is even with a very high R, SARS, MERS were not infectious during incubation period. So once a patient got symptoms, it was very easy to detect and isolate. Even if gonna infect other people, it's very easy to detect as well, because the incubation period is very low, and then you can treat them as well. Another factor, the third one, is it was a short wave. It was a spreading between borders, not an open borders. However, you managed to close the wave in 8 months. So it's short wave, early detectable cases because there is no transmission during incubation. And third thing is low travel rates for infectious patients.
Thank you, Doctor. I think we will take this as the last question from Jihad Al-Naqib. Depending on the forecast models, when it is supposed that COVID-19 will end in the Middle East, how do we deal with the missed data, that is reactive testing, and then will tests be really reliable?
Okay, so that's a $1 million question, I would say. $1 million question. So, most of realistic scenarios are talking about August. So if we're not talking about worst case scenarios, we're talking that in August, the wave 1 will finish in most Middle East countries. However, it depends on whether you're going to open your borders too soon. You're going to open the economy and all the functions and the trading too soon. You're going to lighten the measures and allow people not to wear masks in gatherings. Whether you're going to decrease your awareness strengths in the country or not. So you got a lot of factors. If you are doing exactly what you are doing very high measures and everything is going correct, you will end everything in August. If you are not doing the measures and you try to ease up a bit, it's only going to end up in August. So my advice, whether maybe a governmental official can hear me or not, do not loosen the measures until August, because we've seen in China, we've seen in Europe, a lot of new surge and new cases happen because they opened the trading systems, the gathering and everything. That was the first question, I guess. There was a second one as well, right?
I mean, I myself lost it. I think it was already there. From Jihad. How do we deal with the missed data on that is reactive testing, and when will this test be, and then will tests be really reliable?
Okay, so dealing with missed data for cases and for deaths, it means that we need to put a lot of assumptions, and as of all of you know, a lot of assumptions in any model will lead a high error in the model. So less assumptions, more accurate model. High assumptions, low accurate model. So we are trying to put better assumptions that we multiply cases by 10, by 7, and we'll try. That's why, for example, for countries with no data or low data, we do like 7 or 8 scenarios. With countries with very good data, like UAE, for example, it's enough to do 2 scenarios, 3 scenarios. Worst case scenario, optimistic and realistic. So that's how we deal with missed data. My recommendation is I wish all Middle East countries to go for proactive testing. It will make our life easier. So.
Thank you, Doctor. I will take one more question. It's actually quite similar, quite a tricky one, from Khalid Al-Matrafi and Alam Atif. I think they are asking the same thing. How about recovered people? Do they get an immunity? And if yes, how long it will be? This is from Khalid Al-Matrafi. So Alam Atif question is, why is getting infected with SARS-CoV-2 to get it over with, in semicolons, to get it over with, not a good idea?
Again, on the second question.
I will repeat it. Now, Alam Atif's question is, why is getting infected? He's saying at least, okay, fine, get infected. So you get it over with, not a good idea.
Okay. So we're talking about herd immunity in a way.
Yes.
Okay. So the first question is whether the recovered individual can get infected again or not.
Yes.
So all the time compare it with seasonal influenza. Can a person get influenza in a season and get it again in the same season? It's very rare. It can happen still, but it's very rare. Can he get the same seasonal influenza the next season? Yes. So in this season, it's very unlikely to get infected again. Very unlikely. It's very rare. But in the next season, he will be susceptible again for the infection with the same probability. So for the herd immunity, it's a bad idea if you're gonna let it. Because if you talk about letting go all the borders and say, okay, whoever gonna get infected, but are we really ready for early diagnosis, detection, and treatments? And are we really ready to a high mortality rates from elder people in the Middle East? Herd immunity doesn't mean that all the population of the country will be susceptible and infected. It means from 40 to 60 maximum. But if you're talking about Saudi, 30 millions, if you're talking about 10 millions of the Saudi are susceptible and Saudi people and gonna go for herd immunity, it means that 20%, so 22 millions will have symptoms, acute respiratory symptoms. And it means that you're gonna end up with around 400,000 to 600,000 deaths.
Yes.
So it's not a good scenario. It sounds like, okay, let's end wave one, but it will be somehow a selfish scenario because it will get rid of a selective generation of older people. And you can see the demonstrations in Sweden. In Sweden, there are a lot of march and demonstrations opposing the idea from the government to do a herd immunity.
Very true, very true. Okay, with this, we are short of time now. We end our very, very informative webinar with Dr. Islam Anan. It was very nice, Doctor, to have you with us and to share your expertise. And we are going to have you for 3 more webinars. So all you guys who have joined in for today's webinar, please join us again tomorrow at the same time, UAE 5 p.m. And tomorrow's topic will be the importance of value in healthcare during pandemics. The importance of value in healthcare during pandemics. It's going to be a very interesting one. And I look forward to your presence. Thank you. Stay safe.
Thank you all. Thank you, Dr. Muhammad. Bye-bye.
Bye.
Bye.